patient straightened out so she can get her therapy for you guys?
We're doing subcutaneous.
That's working.
We should be good to go.
That was such a weird thing. Her insurance is that.
Yeah. I had the same problem with Phenotyping, so I thought you guys
Yeah, it's adjustment. So they're
Sorry about that.
I should get backwards jerky.
to that training.
Oh, we had done that already. 4 or 5 Yeah.
What time do you guys have? It's pretty close to 7.
6:58.
Well, welcome back to everybody after winter break, holiday break. Dr. Baran a chance to find a seat. Hope everybody had a good holiday season, Hanukkah, Christmas, New Year's. I had an exciting time. I had a colonoscopy. That's great. I recommend it to all of you over 50. What else did I tell you? Last session I was away. I was in Hawaii, but we had people complaining they couldn't hear the speaker. So Mario's got a lapel mic. I'm going to have to turn it on when he gets up here. So not everybody is outside listening, but either Barb Everett, I know you're listening, or Mike Weiss. Text me if our audio is good, so I know we've got that problem corrected. Otherwise, I think we're ready to go ahead, unless anybody else has got any announcements for the day. Anything new we need to talk about in our allergy division? Phil Henderson, our chief, is in New Zealand vacationing, so he's down in summertime again, missing that windstorm and rain again. Anyway. It's an honor to have Mario Castro here. He's a professor of medicine, pediatrics, and radiology. I don't know how you get to be a professor in all 3 of those disciplines, but it's pretty cool. From St. Louis, and here to talk about really what's a very major evolving topic in his field and our field of the new biologics we've got for treating asthma and related conditions. And I know he's also a national expert in bronchial thermoplasty. So I asked him to talk about all the biologics and also put in perspective where he would place thermoplasty as a treatment modality as well. So thanks for coming to town, and just remind you again to turn on that mic, and hopefully everything will be smooth.
All right, thank you.
The mouse, the mouse, otherwise,
All right. Well, I'll stay back here then, I guess. We're going to come out there, but
well, if you have the lapel mic on,
yeah,
it'll be fine. And if you want to point with your finger,
okay.
We all do that out of habit anyway.
All right. Well, thank you for having me up here. It was I was just finishing clinic late last night, and then hopped on the one flight here. I can still make it, so I'm a little fatigued this morning, but bear with me. I think it's an exciting time. We have a lot of good choices for our patients now, and I think we are really at the cusp of kind of changing this disease, severe asthma, for these patients that really don't respond to kind of the current therapy that we use right now. These are all my conflicts as listed there. The thing is that I basically have spoken or done studies for all the companies that make these biologics, so really have no an equal conflict, say, with all of them. And they certainly do sponsor some of the research that we've done at WashU. So this was a nice review that Mike Weschler wrote, which I think brings up some important points about our approach to the severe asthmatic in our clinic, which is one, defining that they have truly refractory asthma, that they have asthma that is maximally treated and yet not responsive to that therapy, and they can be either controlled or uncontrolled. And certainly if they're controlled, then one may or may not consider that patient for biologic, depending on what does it take to get them to that point of control. And then we start thinking about what is the accurate diagnosis first. I think before we even get to this point about phenotyping, we need to make sure that the patient is truly a severe asthmatic and truly we understand what that phenotype is in that particular individual. I just saw a patient a couple weeks ago who saw one of my pristine allergists, referred to by one of my allergists in our division, seeing one of my own pulmonologists just a couple of years earlier. And in her case, her presenting symptom at that time was refractory asthma that she was referred to me, but she had been on already 3 biologics, and when I was going to see her, she was actually being considered for the 4th biologic, and it all gets back to the basics. Her history. One was her presenting symptom was cough, severe incapacitating cough, and in our field, in terms of asthma, that's pretty unusual in an adult. That is the predominant symptom. Typically, the cough coexists along with a lot of other symptoms in that disease process. In pediatrics, that's a little bit different. Certainly in kids, we can see that as the predominant symptom. The second thing was her examination. I heard some inspiratory crackles, very faint. I was not convinced by that. Then her PFTs were totally inconsistent with asthma, that she had more of a restrictive physiology, didn't have much of a bronchodilator response. And then going back in her records, when our pulmonologist had seen her a few years ago, they had noted a few ground glass spots in her left upper lobe. And in that patient, she had a follow-up CT, and they said it was stable, so they kind of ignored it at that point, which was the wrong thing. We had to go back, really question the diagnosis once she didn't respond. And when we further evaluated her, she in fact had NSIP, a type of interstitial lung disease, non-specific interstitial pneumonitis, that was explaining her severe cough, stopped all of her biologics, stopped all her asthma therapy, treated her with mycophenolic acid, and her cough improved dramatically. So it's, again, thinking about these diagnoses is key. You may recall that in JAMA there was a paper just a couple years ago, or less than a couple years ago, that took a community-based sampling in Canada and found that there was around 30% of community-based diagnosed physicians that were misdiagnosed. And maybe it's not that high in our own academic practices, but maybe we're also fooling ourselves sometimes. So once we narrow down that diagnosis, I think the next part is really to take a phenotypic approach of understanding the disease. And the phenotype is really that cluster of clinical characteristics in that patient population. And we know that asthma, and certainly severe asthma, is many different buckets of disease. And what we've learned is that these clinical characteristics that we've noted for a number of years in our clinic are really being driven by an endotype, an underlying biologic pathway that's driving that disease. In the majority of patients, I would say that we understand that. However, close to 40 to 50% of the patients, we don't understand what that underlying endotype is. And so these are the biomarkers that we currently have available in the clinic. I'm going to talk a little bit more about those in the next slide. And then lastly, unfortunately, the genotype has really not helped us in asthma, in severe asthma. We've spent a lot of money, a lot of time working on this for over 2 decades, and at this point, we have no genotypic markers that we can use in the clinic. We had a lot of hope with the beta agonist receptor that we did several studies in the Asthma Clinical Research Network, but we found out that even in those that had the RGARG genotype, that adversely responded to albuterol when you gave them an inhaled steroid that basically abrogated that response. And so those patients responded normally. So at this point, we really have no genotypic information that helps us in the clinic at this point in patient management. And if there are any questions as we go along, feel free to interrupt. I'm very used to that. The idea here is that a lot of this step therapy, I think, is inappropriate. In that step therapy, to me, as in the national guidelines, suggests that we should keep stepping up and keep adding on therapy. Whereas a lot of this therapy that is added on patients that I see in our clinic, in our severe asthma clinic, on average, they have at least 4 different respiratory treatments, are really ineffective therapies and should be stopped. And so the idea is, how do we stop those therapies that are ineffective and tailor the therapy to those that are effective? And really, I think using biomarkers helps us identify these in these patients, and these are the ones that we reviewed and published in the ATS ERS workshop now 4 years ago. And in this, we identified that there were really 4 groupings: eosinophilic biomarkers, IgE, Pheno, and periostin. And in terms of the first one, we're going to focus on that in our discussion of the biologics, but certainly a lot of the studies that we did initially in biologics have been driven by our understanding of sputum eosinophilia and using that as a correlate of what's happening in the tissue, in the airway. And then, as most of the larger studies have gone on with blood eosinophilia as a correlate of what's happening in the airway. And it's not 100%, none of these are 100% correlate of what's actually happening in the tissue. IgE we have utilized for a number of years. It's a marker of atopy. Unfortunately, has no predictive value. Really helps us only identify whether a person is atopic or not. But the level of IgE does not predict response to anti-IgE therapy, does not predict future exacerbation risk. So at this point, we only use this for that initial characterization of the patient population. One of the things I often are asked about is Omalizumab, anti-IgE therapy. I often hear with my residents and fellows that their IgE was not elevated. Therefore, I should not treat them with Omalizumab therapy. And that is wrong. We know that patients that even have IgE levels in the 40s and 50s can respond to anti-IgE therapy. So it does not have, unfortunately, predictive quality in that regard in terms of when it's high, that it would predict a better response or not. Pheno is a biomarker that has struggled, I think, because of a number of reasons. One is that it has a fair correlation with what's happening in the tissue. It's a marker of oxidative stress. It's a marker of what's happening at the airway epithelium in terms of production of NO. However, it's not a direct correlate of what's happening in the tissue. And so we use it in some clinics. I know in general more allergists use it than pulmonologists. And I think that it's helpful in a couple scenarios. And I'm going to talk about the second scenario when I talk about one of the biologics a little bit later. But the first scenario where it has proven value is adherence. So patients, and in the UK they have basically a Pheno adherence test. They basically have the patient take a Pheno machine with them for a week, measure daily Pheno levels, and if their Pheno level is going down, and they're telling they're measuring adherence, then that patient reflects non-adherence, because once they become adherent to their inhaled steroids, their Pheno levels go down. So unfortunately, we don't have that luxury here in the U.S. In terms of sending these expensive machines home, but it's certainly an approach. The last biomarker here, periostin, is a very interesting biomarker in that we had done some work looking at expression levels of various genes from the airway epithelium, and we saw a signal with 3 particular genes. One was periostin, one was CLICUP2, the third was SERPIN. And these were T2 type of associated gene expression. Now, problem with this is when you take this into clinic, is that 1, you have to demonstrate that it's a valuable biomarker, 2, that it is predictive biomarker, and 3, that it's commercially viable. And so what's happened with periostin is that the last failed, and that Roche, who developed this acquired this biomarker, was probably aiming really to use it with anti-13 with lebrikizumab, and it did not meet its primary endpoint in one of the 2 pivotal trials, and therefore Roche backed off of supporting this as a biomarker. So at this point, this last biomarker is not going to be available unless some other small company takes it forward. Now, this is a review that will be coming out in Jackie in practice, I think this summer in the July issue. But basically what we've done here is we've outlined those targets that are approved in red, and those targets that are still investigational in green. And certainly the green here could be expanded, but the top hits are certainly outlined here. And so I think what's exciting is that we have now the tools to kind of dissect this underlying pathophysiology of asthma. We know that this allergen-driven pathway here in terms of T2 signaling downstream is critical, but we also have recognized that there's non-allergic pathways that are driven by viruses and irritants that also drive this inflammatory cascade. Now, what's demonstrated here is that you have signaling with these upstream mediators such as TSLP 33 and 25, and then downstream mediators such as IL-4, 5, and 13. We know that these mediators have a number of different in-organ effects, so IL-5 stimulating precursors from the bone marrow to cause eosinophil migration from the bone marrow, but also cellular trafficking into the tissue, in particular inflammatory cells that these adhesion molecules are then upregulated, allowing that trafficking into the tissue itself. We know that classic signaling here with IgE causing cross-linking and activation of mast cells and basophils, and then also we know that a number of these cytokines have regulatory effects on the airway epithelium, in particular IL-13 causing increase in goblet cell metaplasia, but also production of IL-5 and trafficking of eosinophils causing damage to the airway epithelium. And then lastly, not to forget, as I mentioned, I'm going to talk a little bit about bronchial thermoplasty, but smooth muscle is certainly a key player here as well, and leading to bronchial hyperactivity. And we also know that some of these targets also have effects on the smooth muscle as well. So it could be modulated by biologic therapy. Now, these are the 5 biologic therapies that are currently approved for the treatment of asthma. I think it's an exciting time for us as asthma specialists, in that we have these tools now to treat our patients. I kind of see us as, the rheumatologists were about 15, 20 years ago, where we were using steroids, bronchodilators, and then we would pull out, these toxic therapies that were ineffective, like methotrexate and gold and all these other things. And we don't have to do that anymore. Our practice has now changed, so we have these 5 biologics available to treat patient populations with severe asthma. Now, I won't go into too much detail about each one of these, but just quickly talk about some of the key studies that have led to their approval. I do note that the only biologic that is currently available in the true pediatric population is Omalizumab, which is approved down to 6 years of age and older. However, these biologics are pursuing indications even over. So they're likely going to go down to age 6. And we're participating in a study, investigational study right now with Omalizumab, looking at it as preventative therapy in viral-induced exacerbations in infants. So it's potentially that this will go into pediatrics in a much larger way than it currently is. So one of the first studies done with Omalizumab was published in the era of inhaled steroids alone. So the original Bussey studies and Solaire studies, those patients were treated only with inhaled steroids. So what I demonstrate here is a study called the Extra study, which was published by Nick Hanania. And this one is really more in the realm of what our patients are getting today, which is inhaled steroids plus a long-acting bronchodilator. And when you add Omalizumab to that, you get about a 25% reduction in exacerbations. And so this is, I think, pretty consistent with our clinical practice. Certainly our comfort level with Omalizumab has demonstrated that it stabilizes patients in their uncontrolled disease. In this one small study, there was an improvement in lung function, the Innovate study, relatively small study. And this is really one of only a few that have ever demonstrated a significant improvement in lung function. And so, in general, when we've looked at effect of Omalizumab on lung function, we haven't seen dramatic differences in terms of changing lung function. And I'll get back to that point a little bit later. Now, there was a subsequent study that came out after Extra. Extra was published in the Annals of Internal Medicine, and then in the Blue Journal, the American Journal of Respiratory Critical Care Medicine, Nick Hanania had went back retrospectively and looked at some biomarkers, suggesting that if you had elevated FeNO or elevated blood EOs, that you would respond better to Omalizumab. So that was subsequently tested in this real-world trial called PROSPERO that was just recently published by Tom Casale, looking at those same looking at those same biomarkers, so blood eosinophil levels of greater than 300 and FeNO levels greater than 25. And in the previous retrospective study, it had shown that if your FeNO was low, you didn't respond as well to Omalizumab, or if your blood EOs were low, that you didn't respond as well. But as you can tell from this study, the PROSPERO study, really no difference. In other words, it didn't really matter what your blood eosinophil levels were, it didn't matter what your FeNO level was. You're just as likely to respond to Omalizumab if you are going to respond. And so, unfortunately, at this point with Omalizumab, that means we really don't have a biomarker that predicts response to Omalizumab. So we're basically stuck with our clinical impression of selecting patients that have that allergic atopic-driven disease that may benefit from anti-IgE.
Just a question. I'm curious what your take is on that. I mean, why do you think that is? Is it local IgE or some effect just on mast cells eventually? Or?
So it's a great question, and I would say that we have no data. Would be the first answer. And I do think it reflects, we don't have a biomarker that's reflecting what's happening at the tissue level, because bronchoscopy-based studies of Omalizumab have shown effect at the tissue level, yet does not correlate with what we're measuring in the blood. And I think it also may be somewhat driven by our lack of understanding the exact mechanism of Omalizumab. As we know from the inner-city asthma study, as well as this study that I referred to earlier, the PARC study, we may actually, Omalizumab's main effect actually may be related more to viral-induced exacerbations than anything. And so we just don't understand that mechanism and how to measure that well. I mean, we're basically stuck with putting somebody on Omalizumab and looking at what happens with exacerbations, right? And that's really unfortunate at this point. We don't have a good biomarker with the biologic that's been out for the longest period of time.
Well,
Yep.
just to follow up on that, so the other thing that's striking here is in this study how much better the response is than the one you just showed. It's a sicker population. They started at 3 exacerbations a year. But I think our experience tends to be either a patient responds very well or they don't respond at all. all.
Yeah.
And you never really see that captured in the studies because they just take the aggregate. Have people tried to break down some of those original studies and say, well, we don't have a biomarker, but if you use a clinical marker of so-called response or not, how effective is the drug really? Does it always bring you down to 0.8 a year, 0.8 exacerbations a year, or what?
So that's a great question. So, make sure this thing comes out here. So right now, when we've looked back at those studies, clinical predictors tend to be prior exacerbations. So, and as nicely demonstrated by this study as well, the more exacerbations you previously had, the more likely you're going to respond to Omalizumab, and that's true with all the biologics. However, no other retrospective kind of analysis of those studies have yielded any particular biomarker or clinical characteristic that helps us beyond that. Now, I do agree with you that the real-world data is very impressive, right? And that we know in all of our clinics that have been in practice long enough that when you use Omalizumab, that you have a select group of patients that respond wonderful to it. But I would also argue that the thing that we've not done a good job is stopping therapy. So one of the things I'll discuss further at the end is kind of cost effectiveness of biologics. And when our practice was with Omalizumab, leaving patients that were not responding on it continuously, it was not a good idea from a health economic standpoint because that really drives the cost without really being a cost benefit from there. So I think as we now have choices, we need to be much better at measuring response. We need to be much better at stopping therapies that patients are not responding to. So I'm now going to briefly talk about the three anti-IL-5s and really, I think, highlight what our understanding is from the pivotal studies, realizing that there is no head-to-head comparison with these three anti-IL-5s. So I can't, and nobody else, I think, in this room can tell you which one is best, right? And I think, unfortunately, we're part of a new NIH network called PRECISE. UW is as well part of that. And we are not going to have a multi-center trial coming out of PRECISE that will answer this question for us. So we'll see what happens in the future. So targeting the eosinophil is certainly, I think, quite obvious now, but for the fellows and those in training here, I would tell you that this approach almost died a little bit over a decade ago. So one of the original Mepolizumab studies targeted patients that were uncontrolled with their asthma. And when they added Mepolizumab in that original study, they reduced the eosinophils. They did exactly what the drug was supposed to do in terms of targeting IL-5, but it had no effect on the primary endpoint in the study of exacerbations. So at that point, we started raising editorials. The eosinophil is dead. The eosinophil is not a key player. And what we failed to recognize was patient selection was entirely the most important criteria for clinical trials in selection of biologic therapy. And what we had to do was really select a subset of patients, at 40 to 60% of the patients that had elevated eosinophils, to put them on an anti-IL-5 therapy. And we know that once we do that and block IL-5, that we're going to block that migration of eosinophils from the bone marrow and the maturation, differentiation, and survival of those eosinophils. And these three monoclonal antibodies all do that. Mepolizumab, Benralizumab, and Benralizumab. The main difference is Mepolizumab and Benralizumab are going to bind the IL-5, whereas Benralizumab is going to bind the IL-5 alpha receptor and block that action on that inflammatory cell, that effector cell. So one of the original studies that was done with a relatively large number of patients was this one called the DREAM study by Ian Pavord, showing that if you selected patients with elevated sputum eosinophils or blood or pheno, that you actually were able to reduce exacerbation significantly with all 3 doses of Mepolizumab. Now, these were all given IV at this point in this study, but it is a very informative study because it is really one of the 2 true dose-ranging studies that have been done with Mepolizumab from 75 milligrams to 750 milligrams. And I would argue that there's really no difference when you look at this clinical endpoint of exacerbations between these 3 different doses. However, when you look at the sub-studies, secondary endpoints, you start to learn something about dose with Mepolizumab. Now, as you would expect, all 3 doses reduce blood eosinophils, and you can see a little bit more of an effect from the higher doses compared to the 75 milligram IV dose. This dose is what is analogous to what we have clinically, 100 milligrams sub-Q. And so where we found a significant difference was what's happening in the airway with sputum eosinophils. You'll note here that the only dose that significantly reduced sputum eosinophils with Mepo was 750 milligrams IV. The 100 milligram dose sub-Q, equivalent to the 75 milligram here, did not. And so some of the studies that I'll allude to subsequently probably explain why we saw in the DREAM study this variable response in lung function, variable response in asthma control. And so I think when we see this in the clinic, we need to recognize that it may be related to the dose of Mepolizumab in our patient population. It wasn't until the subsequent study by Hector Ortega, the MINSA study, that they actually showed not only a reduction in exacerbations with the sub-Q dose, this is the 100 milligram here in dark blue, but also an improvement in lung function that was statistically significant compared to placebo. And that was also accompanied by the Sirius study, which was the oral steroid reduction study that showed that you were able to reduce oral steroids by about 50% of the dose. And you were able to reduce exacerbations even when you reduced the oral steroid dose. In the study, 14% of the patients were able to get off their steroids 100%. And keep that number in mind as we talk about the other 2 oral steroid-dependent studies that have been done with other biologics. The next one is Benralizumab, which is only available IV. It is the only weight-based dosing anti-IL-5 that we have available. It's given at 3 mg per kilo, and this was one of the original phase 2 studies that we did, showing it did exactly what we were expected to in terms of reducing sputum eosinophils even after the first dose, and this was sustained over the 16 weeks of the study. Now, in this study, the primary endpoint was this, the change in asthma control, and we did not achieve that, which was disappointing, but okay, in terms of we certainly saw a signal here. And we were pleasantly surprised that there was a significant improvement in lung function in this short-term study. I want to bring out one of the key points here. People sometimes forget about this article, which is if you have a patient that gives you this history of nasal polyposis, chronic rhinosinusitis with or without nasal polyposis, that these patients respond much better to an anti-IL-5 in terms of their asthma control. And so you can see here a marked improvement in their ACQ from baseline and almost no difference in the other population with IV res. So it's an important phenotype to obtain from the history that selects somebody that is going to respond nicely to anti-IL-5 therapy. We followed that phase 2 study with a pair of phase 3 studies. These studies are just listed here, study 1 and study 2. The pooled results are demonstrated here. And you get about a 54% reduction in exacerbations with IV res in this patient population. You also get a significant improvement in lung function, about 110 cc's over placebo, or about a 220 ml change from baseline. Now, why is that important? Well, res, I think, has consistently across all the studies shown improvement in lung function. So when I think about the earlier data that I just showed you with Mepo, we see some inconsistencies in terms of improvement in lung function, and that's likely driven by the dose in that patient population, by also the weight of that patient. So in the Midwest, we're not as physically fit as you guys up here, and so we tend to use, I tend to use IV weight-based dosing with res in my obese population in the Midwest, and get a much more consistent response than I've gotten with sub-Q Mepo at the fixed dose. This study is coming out in publication in the Blue Journal. Eric Bateman is the lead author on this. And basically what we're trying to do is, now that we have choices, let's measure things that we can measure in the clinic, decide about response, and decide about non-response, as I mentioned earlier, and let's stop therapy that's ineffective or likely to be ineffective, and let's continue therapy that is effective. And so what we did in this study is we find an early response as having an improvement in FEV1 by 100 mLs. You can't see here, but this was ACQ of 0.5 or greater. And if you had this, this was in the first 16 weeks of treatment, so just after 3 doses of IV res, then the results of your reduction in exacerbations after 1 year are demonstrated here. So about 71% reduction in exacerbations if your FEV1 improved by 100 mLs in the first 16 weeks. And then if you had both ACQ and FEV1 significant changes, it was almost 80% reduction in exacerbations. So what does that mean? So it means now in our clinic, we can measure spirometry, we can measure the asthma control test. I don't use the ACQ. I imagine you all use the ACT mostly here as well. And if you see a change in the ACT of at least 3 or greater, that patient is likely going to, in the first 16 weeks, that patient should stay on that therapy, or an improvement in FEV1 by 100 mLs. So these are clinical markers that we can use. We call them clinical response indicators. We wish we had the biomarker. We know that blood eosinophils, if you measure that after given anti-IL-5, has no predictive value. And so we're basically stuck with clinical indicators to predict response. Now, the opposite is true, that you have a far less likelihood of response if you don't have FEV1 change or ACQ change. It's not 0. It's 25 to 30% response, but it's definitely less. Now the other thing,
Are those all the markers you looked at, or were those selected as the best predictors?
so this you'll see in the paper. This is kind of a snapshot of it. It was a comprehensive kind of supervised analysis of all the clinical indicators and biomarkers that were available. I would say the biomarkers, though, were pretty limited in terms of the res studies. They were primarily blood eosinophil levels in terms of biomarkers. We did not have pheno prospectively measured in that study.
I think this is a very powerful way to go. It's sort of what I was asking with the Omalizumab. Has anybody done that? Look at sort of early response as a predictor of long-term response. And that's sort of our clinical impression with these drugs.
Yeah, I haven't seen that as well defined prospectively.
Yeah.
Certainly, there's been studies that look at stopping Omalizumab after a period. Those are responders, right? And then they should, up to 60% of those patients had a recurrence in their symptoms. So I think you have to be, at this point, cautious. We don't have any good predictors yet of Omalizumab. We're using our general impression, and we're using exacerbations as our measure.
Do you plan to do something similar to this with other biologics as well?
Yes. Yeah. And I think it's likely going to come from independent groups as opposed to the companies because, and I'm not sure as well for AZ, but certainly when I've approached GSK about this, they've not wanted to use this kind of approach.
And you picked 16 weeks as an early responder. How far do you go before you call them a non-responder?
Well, this right-hand graph is based on 16 weeks,
Right.
calling them a non-responder.
So you would cut them off at 16 weeks if they don't respond?
I think 4 to 6 months is reasonable. And I would say, I don't think there needs to be a fast rule. It has to be at 4 months or it has to be at 3 months or whatever, because every patient's a little bit different, right? I mean, if you have a patient that has seasonal exacerbations and you're not in the season, you want to probably keep that biologic on board a little bit longer. But at least this data suggests that you probably shouldn't go much beyond 6 months. If I was a big pharmacy benefit manager, director, I would say, you're going to have to prove to me now with the ones that I have choices, unless there's some price advantage, you're going to need to prove to me soon that this drug is working.
Well, it seems to be easier to get the the insurance companies to approve a 6-month trial than it is to approve the drug.
Yep.
So I just wondered if we could use that cutoff period, say 6 months, and say, is that reasonable?
Okay, I think it's very reasonable.
Do you know, I mean, again, it's always hard when you look at group data. On the right, are some of those, is that just a placebo effect that there's a little bit of a response, or do you have some people who actually do respond in terms of their exacerbation rate, and then a bunch who just didn't respond at all?
Yeah, I think this kind of response in the non-eosinophil population has been pretty consistent with the other anti-IL-5 as well. It's in that 20 to 30% kind of reduction. And if you look at the EXER study, that was 25% reduction in exacerbations, you would say, oh, it's working. But that is pretty consistent. And I think it's because the biology is not as simple, right, as just knocking off the eosinophil, that there's other effects on other effector cells that we're likely hitting with an anti-IL-5 in this population of non-responders. We don't know, I mean, actually we've been very interested in the networks to study non-responders, because if we understood the biology behind the non-responders better, perhaps we could figure out what would work better in that patient population. So that's a fruitful area. We don't have much data on that, though. I do want to share with you what we're learning. Now there have been 3 publications of non-responders that have looked at non-responders to Mepo. And this is one that came out of the McMaster group, led by Mukherjee, led by Pram Nair. And none of these are perfect because they're all small, and the control is not 100% perfect, but it is something that is informative. And so when you look at these patients that were treated with Mepolizumab, they were treated with sub-Q Mepo, 100 milligrams sub-Q, and the effect on blood eosinophils was exactly what you would expect, that there would be a reduction in blood eosinophils with sub-Q Mepo. But what this group had noted was that there was a substantial proportion of patients that had lack of control in their sputum eosinophils. You'll note this patient here on sub-Q Mepo has 30% sputum eosinophils. And what they found was that over a year period of time, that these patients would have exacerbations, and they were closely correlated with a spike in their sputum eosinophils. And so that led them to postulate that perhaps if you switch those patients to a weight-based therapy, give them more, in essence, anti-IL-5, that it would help you control that patient's disease. So after a year, after a placebo washout period of time, they then randomized them to Benralizumab pre here, this is post-placebo, and then post-Benralizumab. And as you would expect, did not control the blood eosinophils with placebo, but when you gave them active drug with Res, they did a marked reduction in blood eosinophils. Then look over here in terms of sputum eosinophils, you'll note that sputum eosinophils was pretty much reduced in everybody except this one individual. And interestingly, clinically, the sputum IL-5 levels predicted response. This is one of the only biomarkers and one of the few studies that have shown a predictive biomarker in these patients besides baseline blood eosinophils and prior exacerbations. So to me, this suggests that if you have in the clinic a patient that's not responding to Mepo sub-Q, don't necessarily continue that drug for another year. Switch them over to either an IV weight-based dosing or potentially, as we'll talk with Benra, that would be another option for you in terms of giving a different mechanism of action.
And again, there's no way to predict those patients. In other words, their AEC is not a lot higher to begin with.
No, their blood eosinophil levels, not the only, was the sputum IL-5 levels were higher in those patients that responded to IV res. Okay. Now, the third anti-IL-5 we have is Benralizumab. Benra has this unique mechanism of action, which I like this confocal microscopy, which demonstrates that when Benra binds to the IL-5 receptor alpha, it then attracts these NK cells that are in green here, and they fuse with the eosinophil and basically introduce these lytic granules into the eosinophil, and therefore then the eosinophil undergoes apoptosis. So it really has a very unique mechanism of action in attracting these NK cells through the afucosylated portion of Benralizumab.
Question.
Yeah.
Does it attract other phagocytic cells? I mean, they have Fc receptors like macrophage.
No, not that we've seen, but I would say that it's not been as well studied because this was all done in vitro, so who knows what the in vivo effect is.
But I mean, is there a basis, like they said, why not the macrophage? I mean, they have the same receptor.
Is there a basis for it? I don't know. It's only been seen with the NK cells, though. And so I don't know if there's some specificity there that we don't know about. But it does appear to be specific to the NK cells. So I don't know if it's co-signaling that's occurring that's causing that to be specific to NK cells. Are you talking about
I mean, because
type
it's
2 macrophages, or are you talking about...
yeah, any macrophage has CD16, right?
Yeah.
It's an Fc receptor, and it's an IgG with technically the mechanism is the same.
Yeah.
So why not macrophage?
Yeah, I don't know that. We'd have to see if it's been tested specifically with macrophages or not, because this was all done in vitro.
How about complements? Does it? I mean, it's an antibody antigen. Does it activate complements?
That's it. I don't know that answer to that. Does anybody know? No, I don't know.
I don't remember if it's IgG1 or IgG4 molecule.
I don't know how well it's even been looked at.
I mean, Mepolizumab, they said it doesn't fix complements. I mean, it's in their kind of initial studies, but then nobody talked about that. Is it they never tried, or?
I don't think it's been studied yet that I know of. We certainly haven't, so I don't know. So with Benra, these summarizes the studies that have been done with Benra. The original phase 3 studies were Sirocco and Kalima. This was followed with the Zonda study, the oral steroid sparing study, and then the most recent study that was shown at ERS this past year was called the Bora study, which was a long-term extension study. And with Sirocco and Kalima, I'm not going to go through all these results, but basically showing these studies from that there was about a 51% reduction in exacerbation. So pretty consistent message. All three anti-IL-5s gives you about a 50% reduction in exacerbations. And where you're seeing some differences, I think, is in the secondary endpoints, and those are what you should measure and think about in your patient selection. And you'll note here in the low eosinophilic population, it's not that they didn't have an effect. In fact, they did at this dose of Benra, but it was not as dramatic effect. Now, with lung function, one thing that's unique about Benra is that we're seeing a pretty marked response. So with both Sirocco and Kalima, and this is the FDA-approved dosing where they go Q4 weeks for the first 3 doses, and then go to Q8-week dosing. You're seeing a mean difference here, about almost 400 cc's improvement from baseline, 160 mLs difference from placebo. And so this is very consistent effect we saw in the phase 2 studies as well as the phase 3 studies with Benra, that you not only reduce exacerbations, but you significantly improve lung function. This was followed by an impressive study that's called Zonda. In Zonda, like in the series study, they had a very careful oral titration, very sensitive mouse, oral titration phase where they tried to reduce the patient's oral steroids. And you'll note here that they were effective with both doses of Benra. in reducing the oral steroid dose. But I think one of the key figures that I focus on, which is, I saw 3 steroid-dependent patients yesterday, and I said, the goal here is to get you off completely, 100% off your oral steroids. And that's why we're starting this medication. And in this study, half the patients were able to do that in a relatively short time period, just over about 20 weeks here, which was the oral steroid reduction phase. And so, to me, that's very impressive. If you looked at the earlier study, you recall that I said it was 14% of patients were able to get off oral steroids on sub-Q Mepo. And so we're seeing, I think, a pretty profound effect on enabling us to get these patients off of therapy. Now, I want to end with the last biologic that's just recently been approved, which you're all are likely aware of. This is Dupilumab. Has a very unique mechanism of action because it's blocking this IL-4 receptor, alpha, and that is common in this type 1 and type 2 signaling with the IL-4 pathway as well as the IL-13 pathway. So with this one monoclonal antibody, you're enabling to block both signaling in 4 and 13. And this was the study we recently published in New England Journal in May, called the Quest study, showing about a 50% reduction in exacerbations from baseline in the patients that were treated with either the 200 milligram dose here in orange or the 300 milligram dose. And you'll see this pretty consistently. Both doses are very similar in terms of efficacy with Dupilumab. If you look at lung function, again, an improvement about 300 cc's plus in the from baseline, 140 mLs compared to placebo with Dupilumab. Also, significantly improved the secondary endpoints of asthma control. What I'd like to point out here in terms of looking at change in lung function is these biologics have thrown everything out the window. They're basically showing us an acute effect from a biologic in a disease process that we thought would take months to reverse. And so with one dose of Dupilumab, you'll see that you're almost getting a 300 ml improvement in FEV1 at 2 weeks. That's very quick. And similar data has been shown with Benra in terms of the quick onset of action. So I think this has really changed our thinking. We were so used to looking at patients with Omalizumab and not necessarily seeing that quick effect, stabilizing their disease, but not improving their lung function as we've seen here. So I think that's really interesting. The second, go ahead.
So I hadn't thought about it that way. I agree, it's interesting. Is that just because it's improving what's reversible? Have people looked at the reversibility at those time points to say, okay, well, their lung function's better, but now their reversibility is perhaps less?
Yeah.
Or is it truly changing some structural inflammatory component?
So it has an effect in both the pre-bronchodilator FEV1 as well as the post-bronchodilator FEV1. The magnitude of effect is similar. So it's very interesting.
Yeah.
And in fact, we're writing up some secondary manuscript on this, but what was interesting was that the slope of decline, even in just this year-long study, was basically arrested if you put the patient on Dupilumab, whereas the placebo group continued to decline by about a 40 ml difference. So that's where I'm very interested is, can we use this to kind of change that disease-modifying process, that remodeling that occurs over time? And certainly the data is suggestive, but it needs to be proven we believe, quantitative CT, which is kind of one of my research interests, or with serial lung function. But the problem with serial lung function is that it takes you a very large study over a long period of time to do that. And so we believe it can be done in a less period of time with quantitative CT, or potentially looking at bronchoscopy-based markers as well. But bronchoscopy has its limitations as well. So I want to talk about 2 biomarkers that we studied in the Quest study. One was blood eosinophil levels, and this is the entire reason why the FDA indication says with an eosinophilic phenotype. with dupilumab, which surprised me, but having heard why that happened, I understand now. It was really being driven by this greater effect, almost a 70% reduction in those that had high blood eosinophils. It wasn't that it wasn't working in those that had less eosinophilia, this is greater than 150. It just wasn't as effective in that population. The second thing, which I think is music to the ears of Circasia, which makes the device that helps us measure FeNO, is that this biomarker helps us select patients that are going to respond to dupilumab. If you'll note here, those that had a FeNO greater than 25 parts per billion had a 65% reduction in their exacerbations. Very consistent effect when we look at lung function as well. So this was independent of their blood eosinophilia. So if you have a patient that you're looking for eosinophilia, you don't see it, you get a FeNO, and it's greater than 25 parts per billion, this is the drug of choice in that patient population. And we believe that that's being driven by IL-13, mechanism of action on the airway epithelium that is responsible for increase in FeNO arginase expression in severe asthma, and then looking at increased expression of nitric oxide.
Has that been sufficient to get the drug approved? Is to have insurance companies paying for it based just on the FeNO?
Yes. Yeah, I've had patients approved.
Even if they don't have an eosinophilic phenotype?
Yes.
And why is it that this is not a drug that directly involves eosinophil biology, IL-4 and IL-13? Why is it correlating with eosinophil count?
So I think because of the redundancy of the biologic pathways, so T2 inflammation doesn't mean that you don't have eosinophilic inflammation. You do have eosinophilic inflammation, and when you select patients that have enriched eosinophilic inflammation, they're going to respond better. So it's really, I think, just the overlap between what we know about the T2 biology and eosinophilic inflammation that's explaining that. And it makes sense from the standpoint, even when you look at the anti-IL-5 data, the more likely you're going to respond to an anti-IL-5 is being driven by your baseline blood eosinophil count as well as your baseline speed of eosinophil count. So the higher that is, the more likely you're going to respond because that's the predominant process that's driving disease.
So you mentioned earlier that, like after the failure of Mepolizumab, they kind of look for patients who have eosinophilic phenotype, and they said people have, you mentioned, that have high eosinophil, high FeNO, and high blood eosinophil, high speed of eosinophil, high FeNO, but later on all the studies just focused on the blood and they forgot about the FeNO. So what happened in that?
Well, the problem with the anti-IL-5 is that FeNO is less specific for eosinophilic inflammation, and so it is not performed as well as blood eosinophil levels did as a correlate of what's happening in the lungs. Whereas with dupilumab, different mechanism of action, where FeNO is a direct measure potentially of IL-13 effect, and you're blocking IL-13, then I think it's a better biomarker for dupilumab.
How about periostin across all of them? I'm sure it has been tried. Why the failure with dupilumab?
Yeah. So periostin has been measured, as well as a number of other biomarkers. There's a paper coming out, and some of the biomarkers were mentioned in this Quest study, and it was significantly reduced with dupilumab, but it did not have very good predictive value of response. So a biomarker is a biomarker, but truly what you want is a predictive biomarker, and it turned out that FeNO and blood eosinophils outperformed periostin in this particular study in terms of prediction. Yep.
How do patients feel at that 2 weeks, 1 month into it? Do they feel like significant difference?
Yeah, it's amazing. Patients, I always support companies when they give me samples because I get them started on therapy as soon as possible. Some of our patients are coming from 4 or 5 hours away, and you want to get them on therapy as soon as possible. So I give them a sample, put in their paperwork, and get them approved for it, and then continue their therapy from there. And it's because when they come back, even at that 4-week appointment, they're noticing a difference already. So it's pretty remarkable in terms of that story that you hear. The last study I'll mention. Oh,
How about atopic dermatitis as sort of a clinical predictor? I mean, I know and I think others had been using the drug in atopic derm in patients with severe asthma and had seen dramatic effect before this study. Did you see here, or did you have the power to see if they
Don't have
wanted
the power.
better?
Don't have the power. And even in my practice, I had just 3 severe asthmatics with AD and had put them on Duping as well before it got approved for asthma, and saw a response. But in the studies, we did not have sufficient numbers. So the last study I'll mention is the Venture study, which came out together with Quest, very similar to Sirius and Zonda. The main differences here, again, 70% reduction in oral steroid dose. 100% of patients, half of them, 52%, almost the exact same, it is the exact same number from Zonda, and that half the patients are able to get off oral steroids. So the patients that I saw yesterday, 2 of the oral steroid dependent patients, I started on Dupy. I had no blood eosinophil levels, had elevation in their phenol, and had been on oral steroids, one of the patients up to 40 milligrams a day for 5 years. And so these patients, the indication actually says oral steroid dependent patients are indicated for dupilumab. It says that second part of the indication does not have the caveat eosinophilic inflammation. And the reason is that in this study, baseline blood eosinophils did not predict response to dupilumab. And so to us, this is very important information from the standpoint of that oral steroid dependent asthmatic now that you're struggling to try to demonstrate one blood eosinophil. You now have a choice for that patient. And in this study, there was a 60% reduction in exacerbations and statistically significant improvement in lung function. And of the oral steroid dependent studies, this is the only one that has shown a statistical improvement in lung function in this patient population so far. I'm not saying it doesn't happen with the other anti-IL-5s, but it definitely was demonstrated in this study. The main difference with dupilumab in terms of side effect profile is that injection site reactions happen. So 1 out of 5, 1 out of 6 patients complain of pain with the injection. I've had some my own site. They say that when you inject it, it's painful. It's not necessarily because I don't understand. It's not like Xolair where it's viscous and so on. But it only lasts with the injection and then it resolves. So patients put up with it in that regard. The eosinophilia, I think, is related to the mechanism of action, and it appears to be transient. It tends to dissipate after 3 to 4 months. So talking about other diseases besides asthma, there's chronic rhinosinusitis with nasal polyposis. Sanofi Regeneron is pursuing an indication in this patient population, showing here that a marked improvement in the nasal polyp score in these patients treated with dupilumab, as well as pursuing an indication for eosinophilic esophagitis based on this patient-reported outcome, showing a significant improvement with dupilumab in EOE patients. These are all the biologics that are being pursued. This is not a comprehensive list, but a pretty good list. Certainly the ones that are likely to be coming out soon with their phase 3 studies are tezepelumab and fevipiprant, which are upstreaming mediators that I mentioned earlier. And as I mentioned earlier, the anti-IL-13s have been discontinued in terms of the pursuit with asthma. So for those that are interested in training in allergy or pulmonary, this is an exciting field. We have a lot of work to do in the future, a lot of opportunities to tackle non-eosinophilic disease, which has become the focus of our severe asthma research program sponsored by the NIH. In the last few minutes, I'd just like to end with a case here. This is a patient that I treated, and I'll quickly go through this. But this patient was on chronic oral steroids, 20 milligrams per day, had been treated with Mepolizumab when he was referred to me already for 3 months. And at that point, he was quite symptomatic, having frequent nocturnal wakings. His quality of life was so impaired that he said to me he was desperate. He used to work as auto detailing, but that would trigger his symptoms, and therefore he stopped doing that. He had comorbidities. He did have chronic rhinosinusitis. He was on the usual treatment, Genostep 5 therapy, in addition to a biologic at that point, 100 milligrams sub-Q. His testing is demonstrated here. He was pretty severely obstructed, FEV1 at 42% of predicted, but did have a significant bronchodilator response, did have a marked bronchial hyperreactivity as demonstrated here, and his IgE was 79, and his blood eosinophils was 150. Now this was on 20 milligrams of prednisone at that point, and you can see his ACT was rock bottom at 6. So at that point, we said, well, maybe he hasn't been on Mepo long enough. He'd only been on it 3 months. So we added a LAMA to his therapy, given his severe airflow obstruction, and we switched his LTB4 to LTB4 antagonist, and we made sure that he was taking his medication correctly and evaluated him for dysfunction. We subsequently saw him 6 months later now. I followed him for over a year and a half now, and he was still quite symptomatic. He wasn't convinced I was a very good doctor, and he was still on 20 milligrams of prednisone. But at this point, I had seen him for 9 months on Mepo, and I was pretty convinced he was a non-responder to Mepo. So he was originally referred to me for consideration of bronchial thermoplasty, and this is where I bring this in. He had no vocal cord dysfunction on provocative examination, and so we decided to go ahead with BT in his case. And in his case, I'll quickly show you, he underwent BT across 3 treatment sessions. So these were his actual treatments in the airway. And we were using hyperpolarized gas to look at small airways disease. So in this patient, this is his baseline hyperpolarized xenon study. And this is after bronchial thermoplasty. So basically, we're restoring ventilation to the small peripheral airways in these patients with bronchial thermoplasty. Now, in this patient, we actually were able to reduce his oral steroids. So when we did that, his biomarkers were repeated. Now his blood eosinophils were 600. And at that point, we discussed with him kind of what his goals of care were, and we decided to go ahead and add Benralizumab to his treatment. His lung function went up all the way up to 89% predicted. He almost doubled his lung function in essence after adding Benralizumab. And he was able to completely come off of his prednisone now, and his ACT score now is 20. And this has been a sustained effect now over the past year in this individual. So I bring this case in that we're in a fun time, that we can use combination of biologics to target the eosinophilic type. We can use biologics to target IgE predominant disease. There are going to be these patients down here that are not going to have these phenotypes. And we could consider a macrolide in that patient. There's only been one study so far that has been positive in that group. But I would say targeting airway smooth muscle, I would prefer, preferred therapy should be bronchial thermoplasty at this point. And this patient really, I think, nicely demonstrates that you can combine therapies, targeting smooth muscle as well as targeting IL-5 in a patient and achieve a dramatic response in that patient population. So I'll end there and open it up for any questions you want to answer. Thank you very much.
In that patient, how much of his improvement was thermoplasty and how much was Benra? Couldn't gather that.
Yeah, so, and there was a interval there of about 3 to 6 months that we were observing him. His ACT had improved, but his lung function hadn't really budged that much. And I was able to reduce his oral steroids in half, basically.
You're talking after thermoplasty.
After thermoplasty. But I wasn't able to completely get him off. And so at that point, I said, and his eosinophils have popped up. And so I said, let's put you on an anti-O5 and see what we can achieve.
We had been on an anti-O5. Why'd you take Benra over Res?
Well, I think in his particular case, he was overweight. And I think his failure to Mepo response was likely related to lack of adequate dosing, whereas the mechanism of action of Benra helps you overcome that effect. And so that's why I chose Benra.
Well, I'm surprised. Earlier you said since you have weight-based
Yes.
dosing for
Yeah.
Res, that's perhaps its advantage.
Yeah, and that's, again, where, it's called shared decision patient making. This guy travels about 5 hours to see me from Springfield, Missouri.
So I agree with practice.
And so, in that locale, IV res has been very difficult for me. And so I went with Benra in his particular case.
Did you use his pheno to decide to use that versus dupilumab? Or is that just
Well,
your gut feel?
This was pre-dupilumab. So now, we would have that to throw into the response. I would say with a blood eosinophil of 600, anti-O5 looks very attractive in that patient population. But I would not fault anybody to say dupilumab would be an option in that regard. Interesting, in bronchial thermoplasty patients, since we're scoping a lot of these severe asthmatics, there's some that just produce tons of mucus, and I'm very interested to see how dupilumab is going to work in those mucus phenotype. And we have a study that we just published in JCI this past year that says if you look at a quantitative, look at a CT and count the mucus plugs that you have in a patient population, that mucus plugs highly correlates with the T2 phenotype, and that then potentially, that would be a good target for a drug like dupilumab. That's not been tested yet.
I gathered from your presentation you think there's a place for each of the anti-IL-5s based on patient selection. There have been these two papers trying to compare, even though there are no head-to-head studies, and trying to make a conclusion. Bussey's paper suggesting Mepo is better, and a colleague in the room here's paper suggesting they're equivalent.
And Tom Casali has a paper that says Benra is better. It's to me, indirect comparisons I find very problematic, and depends on who sponsored the paper. Surprisingly, their drug came out on top. And so I would say that they're okay, they're interesting, provoking, but does not help me in the clinic make a decision at this point.
Fair enough.
You're showing fairly modest increases in FEV1, like 0.1. Do you feel that your technicians can give you that kind of accuracy when you do those testing, or is that just giant?
Yeah, so this is
Data
the whole,
points.
This is the whole thing of interpreting placebo response, right? And I've struggled with this as well with bronchial thermoplasty in terms of looking at change from baseline. I would argue that for the individual patient, all they care about is where they change from baseline, not over placebo. And so when you say that it's a modest effect, 110 cc's, that's correct from a trialist perspective, from an academic perspective, but from the patient perspective, they don't care what it is over placebo. They care where they came from, right? And so when I see improvements of 300 to almost 500 mLs in FEV1 from baseline, I would say that that's not modest, because these patients started off with FEV1s on average around 1.6 to 1.7 liters. And in fact, the earlier data that I showed from Bateman, that Bateman article, I use in my clinic. My spirometry has to be done before that patient gets in the room. And when I see that improvement in the spirometry, I know that what's going to happen when I go into that room in that patient. So it's, I think they are modest when you say compared to placebo, but I don't think that they truly are modest from the patient's own perspective.
Well, that was sort of my question, but I'm wondering about from one person to another. Because in my clinic, if we send him to the pulmonary function testing technicians, he scares the crap out of the patients, and I get like another liter of FEV1 out of these people versus my own nurses that do this.
Sure.
And I just wondered, with numbers that are that small, do you find that there's a personnel difference in your studies, or do you always have the same person do everybody?
I would say in our pulmonary function lab, we get a pretty consistent effect. And I do agree with you that when you're looking at different locales, spirometry from different locales, we do see quite a bit of variability. And
Like you said, it's what the patients think, so it doesn't really matter. But
Yeah.
it's just when you're measuring
we know
0.1
placebo
liters,
affects even FEV1, right? So, you know, it is something that is an effort-dependent test, right? And so we thought the FEV1 is completely effort-independent, but yet there is a significant placebo response there. So I don't discount it. I just say that from the patient perspective, it doesn't really matter what that placebo response is, right?
Okay. In the Dupy trial, was it done? Were they dosed at home?
So in the Dupy trials, the initial doses were observed in the clinic, and then they were allowed to do self-administration if they wanted to.
How was compliance?
So compliance in the observed trial was very good. That's not a real-world pragmatic trial, so so we'll see. But it is a concern that we have in self-administration. And I would say, though, what does hearten me, though, in terms of thinking that it's going to be okay, is that adherence to anti-IL-5 therapy has been tremendous. In my clinic, it was over 90% that they would either come in for their infusion or come in for their shot. My experience with Omalizumab, it was around 60% in the inner city population. And so, to me, when the drug works, the patient knows that, they're going to be much more adherent to that. But you're right. You know, what if they say, "Oh, I'm paying $500 copay. I should do this every 4 weeks," and yes, you know, so there are going to be issues.
Or I feel better. I don't want to take my medicine.
Yeah, exactly. Yeah. Well, thank you all for having me. I really appreciate it.
It was better at predicting tolerance than
I actually worked through this morning on
but I was trying to protect her.
I mean, because you don't want to stop.
Correct, and that was one of the things that we I'll be great at telling people.
The other thing
So from an office standpoint,
Right.
and
And I think if I had to approach other people,
the other alternative would be Thursday. Do you have any preference? Because I said I'm not going to push you.
I don't Monday and Friday. Yeah, I'll only Wednesday.
I'm not sure I'm ready to go. That's it. But,
So, see, it's nice that your priorities are straight. So that's appropriate. So then I can use that lunch. I can say, he can't work on Wednesdays because of going. So Mondays and Fridays, and then one day would be, see, the problem with Friday is that we only have 2 people in the office in here.
yeah, I think
And the 2 of them manage and device spot for Fridays because they don't take time off on Fridays. So then I end up working like 1 or 2 days a year because we both want to take the same day off. And then they close the clinic. I said, we can't do that.
So Bill and Nan are going to go.
Anyway, everybody's excited that you're coming. So I'm excited that you're coming.
Good, I'm excited too.
I'm just hoping that the state stuff goes. So I filled out your thing yesterday. It's a stupid question. Yeah, 7777. I don't know. 77. It's like, why would you even ask these questions? But it's just interesting. So, but I didn't know, and I just told him I'd ask you what days you wanted. And they said if you use Dragon, they'd like you to use Dragon instead of instead of fussing with Epic, but you can have.
Well, now what do you mean by that?
So,
I've used Dragon.
That's what they said. Dragon's cheaper than a Scribe. So what they're trying to do is see, can they get you to use Dragon and you fumble through Epic instead of getting you a Scribe? And I said I could ask.
Well,
But you'd get some training and they'd show you what you do. So if you're as bad as me on Epic, you'll learn in a day what you need to do, and then if you can use Dragon, then you don't need it. It's just to click a bunch of stuff.
well, I'm fine. I mean, if I'm only working 2 days a week, I'm sure I can.
Well, Mike, you can work more if you want.
Well, I mean, no, I mean, that.
How are you? I was talking to Todd, we were talking about Dr. Batari.
Is this something that you could go back from?
We're still working on it. For some reason, it's contract glitch
That's
as far as the speaking.
Anyway, but I'm
So I
excited
hope they cut
because.
that down. It's you guys don't have any
And
invitation.
they're gonna, let's just get a local dentist. He said, no, let me talk to Mike, don't get any local anybody. So anyway, but I just
So you can
told him I'd
he's
ask
coming.
you to get a
Yeah, he's coming. I'm
because I knew you had said something about golf.
Golf is one.
And these guys are
But
colleagues.
any other.
Yeah, it's his name's up here.
Yeah.
Fair enough.
And I don't know.
And they work with my son also.
Oh, okay.
I work Monday, Tuesday,
So,
Wednesday,
fine,
Thursday.
just keep me posted.
And then I got off Fridays because Ann said, I was already off Monday. She said, well, I'll take Friday. I said, I think I'm going to get Monday and Friday. That's not really fair. And then she goes, well, that's what she likes. So who's Jen Lee?
Yeah.
She's the one that's leaving because she and her husband both got the
That'll
diet
help.
on
The
it.
problem
She's
with it always is the
she's
mixing and
retiring at
preparing
45.
it.
Boy, he mentioned
So I think she's gonna
So
have
it's
to
ready to use?
Yeah, that's a number.
viscosity.
So anyway, but that was the question.
It's
All
way
right.
less viscous.
Well, I met.
Less viscous than the other. So the additives for things that are stabilizers and hard stuff.
Hey Matt, you gonna grab any of this? No, I gotta get there.
Breakfast?
Yes.
Good. Oh, Thursday.
So, I thought you, we be able to speak briefly about
No, oh, okay.
I mentioned briefly before, but she wants me to not be involved. Okay, yep, so she's gonna, we're gonna go sit down here just at 9:30 for a night. We're gonna sit down and go through all your patients and where we're at with all of them. And then she's gonna come to us and see if there's anything that we can do to help get these patients pulled through. So, but since I can't get patient information, she thought it would be better for me not to be there.
You're gonna take all this stuff and get it out of here? All right.
Okay, perfect. Do you need anything from me?
No, I had to fill out some documents.
Yeah, the printer.
I did it once, and it said it didn't print, so I have to do it.
And this ball, the foot,
I did it when I was in Hawaii.
Had a couple too many vitamins.
No, I did it right. I did it right. They said it
Have you been?
No.
Oh.
No, I just saw a picture.
Oh, I was like, wow, most people haven't even heard of it. Like,
Oh,
like
no.
wait, where did you go?
And I gave it to my wife for Christmas.
I feel like I went.
Oh, yeah.
That's like,
Yeah,
I know
bring
myself. It was like, I told you about
your
it.
extra conversion.
Yeah, I was like, this is great. Well, after you get changed, do you have a good holiday? Thank you. You want me to?
Are older, so it's.
Yeah.
I honestly didn't. I have no idea what you said before.
But they're 1.5 and 3, so it was fun to be around. Yeah, exactly. And good opening gifts and all that. So,
Yeah, just wait.
yeah.
That's something.
Hello, Sarah.
Hi, how are doing very well. How was your holiday?
It was good. Yeah. How's the last?
It's good.
Yeah.
So you're gonna head home?
Yes.
No, I don't.
Yeah,
That question, do you need, are you gonna follow up with them?
Yeah, I'll be excited.
So we just did like a
Oh, okay. Okay.
yeah, I call it.
Correct. So just say if they want to. I actually don't say.
See ya. Are awesome.
I know, I love those.
Those are awesome.
I'm a shoe person.
Oh,
so I
no,
see
okay.
a lot of shoes. Do you live in Seattle?
Yeah, so I live in
Okay.
Get to it today, huh?